Welcome to the State Health Registry's video training series. I'm Lori Summers, the trainer for the Iowa Cancer Registry. This video covers the breast anatomy and extent of disease staging. When all of the subtypes are combined, female breast cancer is fairly common. In 2020, it is estimated that there will be 276,000 new cases of female breast cancer. The breast cancer subtypes with the HR positive, HER2 negative is the most common subtype. So hormone receptor positive and HER2 negative is very common. The age-adjusted rate of 87 new cases per 100,000 women is based on the 2013 to 2017 cases. This is a rate more than 6 times higher than the triple negative breast cancer rate of 13 and the hormone receptor positive, HER2 positive breast cancer rates of 13 and over 15 times higher than the HR negative and HER2 positive breast cancer rates of 5.5. All of those rates are age adjusted. HR is the hormone receptor, so HR positive means the tumor cells have receptors for the estrogen or progesterone, which can promote the growth of HR positive tumors. HER2 is the human epidermal growth factor receptor 2. So HER2 positive would mean that the tumor cells make high levels of a protein called HER2 neu, which has been shown to be associated with certain aggressive types of breast cancer. So this pie chart shows the percentage of female breast cases by cancer subtype, with 68% of the cases being hormone receptor positive and HER2 negative, which is shown here by the darkest color. The other terms you might see, luminal A or luminal B. Triple negative is another term they use when all three of those are negative, or HER2 enriched if you have a HER2 positive. So you might be seeing these terms in your record. The anatomy of the breast is shown here. Remember that the breast itself has no muscle tissue. A layer of fat surrounds the glands and extends throughout the breast. Note the muscle behind the breast, shown by F, and G is the chest wall and the rib cage. These terms will be mentioned in procedures if there is a larger amount of tumor that needs to be extensively removed. And here's a look at the breast lymphatics. They drain by 3 major routes: the axillary, the interpectoral, and the internal mammary, noted here along the rib cage, F. So intramammary nodes reside within the breast tissue and are designated as axillary lymph nodes for staging purposes. And note the levels of the lymph nodes on this slide. Axillary or low axillary would be level 1. Mid-axillary would be level 2. These are the routine levels of nodes removed at dissection and coded in SSDI. Mets to any other lymph nodes, including cervical, contralateral, internal mammary, or contralateral axillary lymph nodes, are classified as distant or M1. The TNM manual does an excellent job of sorting through the regional lymph nodes and shows a nice diagram. Involvement of level 1 or level 2 nodes assigned to AJCC N1 or N2 clinically or pathologically. Involvement of level 3 nodes is assigned to AJCC N3, and this is defined as METs in ipsilateral infraclavicular or level 3 nodes. There is only a pathologic N3 category and not a clinical N3 category. Level 3 nodes are not typically removed. If they are, you will need to look for a statement and text this information specifically. These should be identified separately by the surgeon for microscopic evaluation. Here are the site codes for breast. The solid tumor manual sends you to the SEER or the COC manual for a priority list for using documents such as the mammogram, op reports, or path reports to determine the tumor location. In fact, the SEER main manual says to use all of the information in the chart. But as you know, site-specific rules always override anything in the general rules. We'll look at the priority order for breast in a few more slides. Table 1 in the Solid Tumor Rules Manual is your best source for coding primary site. This is an updated list of terms used in Table 1, Column 1. So please use this table first when you're deciding on coding a primary site for breast. I've snipped in all 3 pages here just as an example. I've scaled these down. So note the detailed terms and descriptions in the first column. These terms are expanded from any other resource that we have. This is a helpful diagram that shows the position of the tumor described on the face of the clock. This diagram is in the Solid Tumor Rule Manual under Illustrations. Use the information from the reports in the following priority order to code a subsite when there is conflicting information. So, and this can happen a lot where the exam might show one area of the breast, the mammogram might show another area of the breast. But if you have an op report, use the op report and stop there. Don't keep going down the list looking at what else you have. They did remind us in one of the recent NACER webinars in these priority orders for coding anything. If you have number 1, stop there and don't look at the rest of the list. So the best information for primary site for breast comes from the op report. If it's not stated there, then go to the path report. If it's not stated there, then go to the mammogram or ultrasound. This coding subsites does come from Appendix C for the breast, and also code the subsite within the invasive tumor when your path report states that you have in situ and invasive. You're always going to code the subsite that has the invasive tumor. If you have multifocal tumors in one quadrant, code that subsite. So all of those multifocal tumors could still be in one quadrant. And then you want to code the quadrant, not C509. To code C508, Remember, this is a single tumor that is large enough to cover 2 or more subsites, and you cannot tell where the tumor was originated or if there's a single tumor at the 12, 3, 6, or 9 o'clock position. So to code a C508, it has to be a single tumor. To code a C509, this is multiple tumors, so 2 or more, in at least 2 quadrants of the breast. And all of this information came from the coding guidelines for breast in the SEER Manual Appendix C. Laterality must be coded for all subsites. If you have a breast primary with positive nodes and you don't know there was no breast mass found, then you're going to code the laterality to the side with the positive nodes. Okay, let's move on to the extent of disease staging. The breast anatomy is pretty basic. Not a lot of different anatomical things going on there. So let's go into the EOD staging. Remember, there's no EOD manual. So the EOD schemas are found in the SEER RSA. Here are the notes for the EOD primary tumor for breast. You can follow along if you want to. In the SEER RSA, there are 4 notes. These are the details that you'll need to text so that you can back up your codes. So any of these identifiers in note 1, such as dimpling of skin, nipple retraction, really are related to tension on Cooper's ligament, not actual skin involvement. So they do not alter the classification of extension. If you have terms like adherence, attachment, fixation or induration, or thickening, these are all clinical evidence of extension to the skin or the sub-Q tissue, and then you would assign a code 200. If all you have is fixation NOS, that is determined to be an involvement of the pectoralis muscle. You would still code 200. For a clinical description of inflammation, redness, swelling, peau d'orange, which is that thick orange peel type skin, or any other terms that describe skin changes without the diagnosis of clinically stating they have inflammatory carcinoma, you would assign these to 400. So let's look at these initial codes here. These are the in situ codes for primary tumor. Paget disease is a unique disease that can be in the nipple with or without underlying tumor in the breast. It is only in situ if the underlying tumor is in situ. If the underlying tumor is invasive and you have Pagets of the nipple with underlying invasive, then the Paget becomes invasive. Some stage 18 for these 3 codes would be in situ. So what is Paget disease of the nipple? Here's a picture of the disease of the nipple. This may or may not be a sign that something is going on underneath the breast tissue, but this could present as redness or scaling, flaking of the nipple. And like I said, there could be an underlying in situ tumor or an underlying invasive tumor. Moving on to the invasive codes, the most common code you will use for this localized type of tumor is 100. If you have skin involved, remember to move on to code 200. And this would be some stage localized. Extension of the breast is pretty easy unless you have regional disease. Note 2 and 3 talk about coding 200 because of fixation. So notice that code 100 states nipple and or areola, as does code 200. The difference is the skin involvement. If there is skin involvement, go right to 200. If there's no skin involved, code 100. This would be a some stage regional. Codes 300 and 400 are pretty clear. This is still invasion and not METs to the ribs. Note 4 includes code 400 when you have skin involvement, but no clinical statement of inflammatory carcinoma. This is some stage regional. Okay, so let's flash back a minute to the anatomy and see what the extension codes are talking about. Code 200 is asking about the pectoral muscle fixation or invasion to the muscle or subcu tissue. Remember that the muscle lies behind the breast. There's no muscle tissue in the breast. Code 300 is asking if it has invaded the chest wall, the intercostal muscles, or the ribs. So again, this is behind the breast. So you can see there could be extension to the ribs without it being METs. Code 400 would be extensive skin involvement and focuses on the skin overlying the breast. So this would be outward growth towards the skin. And just another picture here, a good anatomy reference, looking at the skin, the fascia, the pectoral muscle here down at the bottom, just gives you another visual of the layers of the breast. So then code 450 starts the diagnosis of inflammatory carcinoma. This is still considered some stage regional. NQRAS is a dramatic presentation of METs from the breast to the skin, a cutaneous clue for systemic malignancy. It also means that a cancer that involves a considerable portion of the skin. Code 500 is one of those combination codes where you have 300, which is invasion of the chest wall muscle or rib, plus 400, the skin involvement, without inflammatory breast, or 450 with the diagnosis of inflammatory breast carcinoma. So those combination codes can be tricky. Again, some stage regional. Both codes 450 and 600 require a clinical diagnosis of inflammatory carcinoma by the doctor. So what is inflammatory carcinoma, or IBC? It is a clinical manifestation of an underlying cancer. The path report won't state inflammatory as it is not histology. The path report may state invasive ductal carcinoma, and the clinician then diagnoses the inflammatory breast cancer clinically. According to the American College of Pathologists, inflammatory carcinoma requires the presence of clinical findings of erythema or redness and edema or swelling, involving at least 1/3 or more of the skin of the breast. We'll talk more about the inflammatory breast cancer when we get to the solid tumor rules, but according to Rule M2, inflammatory carcinoma is a single primary, even if it's in multiple quadrants of the same breast or bilateral breasts. Text clearly the defining signs of inflammatory breast cancer to back up your codes, whether you have a statement of IBC or just the symptoms of IBC. So you're looking in the record for terms like swelling, inflammation, redness, erythema. You can see this orange peel, peau orange, that makes the breast look like the skin of an orange peel. So those are the things you're looking for. And then clinically, the physician would diagnose inflammatory breast cancer. Okay, so the EOD regional nodes. In our QC review of this field, we found 73% correct rate, and this fell below the Sears goal per field of 85% correctness. A lot of common errors were coding a path negative lymph node to 000 instead of 070. The other common error was using terms to code nodes or involved using imaging terms. There is a list in the EOD manual of terms used to mean lymph node involvement, and that's on page 25. Because this is a troublesome field, we're going to go through each of these nodes. So obviously code only regional nodes and nodes NOS in this field. Any distant nodes are coded in the EOD METS field. Note 2, if nodes are pathologically positive and the size of the METS is not stated, you will assume the METS is greater than 0.2 millimeters, and you're going to code the lymph nodes as positive. Note 3, if regional lymph nodes are removed and there's no mention of level or another specific type, assume these are level 1 and 2 lymph nodes and code them appropriately. Note 4, lymph nodes with isolated tumor cells or ITCs only are not counted as positive nodes. Then there are specific codes for nodes, whether you have negative nodes on path and positive isolated tumor cells are found on further testing, like the RT-PCRs, if it was found on IHC, were the lymph nodes positive or negative for isolated tumor cells. Note 5, codes 100, 200, and 350 only apply to level 1 and 2 nodes. If you have internal mammary, infraclavicular, or supraclavicular nodes, then codes 100, 200, and 350 may not be used. So do not confuse internal mammary with intramammary nodes, which are routinely evaluated. So remember, F is internal mammary, it's its own chain. Intramammary would be within the breast, any lymph nodes that are found within the breast. So make sure you can clearly identify those. Also, remember, internal mammary are not the nodes that are routinely evaluated. Okay, note 6, you can code 800 if regional lymph nodes are involved, but you don't know the number of the nodes involved and it just says regional nodes positive. Typically, you're going to know, have better information than that. And then note 7, I just pasted in the list that they have provided of what is considered a regional lymph node. And they've broken it down with level 1, 2, and 3 lymph nodes. So that is also helpful to just have a good reference of those. Okay, so looking at the table of the codes, I have added a P or a C to show which codes are clinical or path. These are not in the manual, but it's just helpful as you're learning to realize that they're really mixed up. So do not code a path negative node in 000. It goes in 070 if the lymph nodes are removed and they are pathologically negative. That is a common error. It's very easy to just think negative and grab the 000. So just a caution. So these groups of codes are for pathologically positive, with the exception of 150, 350, and 400. And so I pulled those out on the next slide. Read each code carefully and note whether you have clinically negative or pathologically negative or positive nodes. Remember, these codes cover all of the level 1 and level 2 nodes only. And then if you look at 350 and 400, again, these are the clinical assessment. These are all regional, some stage regional nodes. Okay, so we do have these 3 codes for clinical only. Look at codes here on this slide. These are clinically positive lymph nodes. These are all considered positive. These would be some stage regional. Code 500 begins the level 3 nodes. So these group of codes are for pathologically positive lymph nodes. Again, read each code carefully. These are all some stage regional, except for code 700, which is distant. So there are a lot of words and a lot of terms in these regional lymph node codes. So just use them with caution. All right, we'll move on to the EOD METS field. There's only one node and it pertains to bone marrow micromets. If you have bone marrow micromets, circulating tumor cells, or disseminated tumor cells in clusters, and they are less than or equal to 0.2 millimeters, there is a code 05 that we will code those to. So here are the codes, and it's really a change in how we are looking at the METS field. Code 00 is both for none or unknown if distant METS. We are no longer coding 99 for METS field. This is in line with AJCC, and we now assume that we do not have METS unless it is stated that we do have METS. So this is really across all sites, not just breast. So you'll always code EOD METS to 00 unless you know there is METS. Code 10 shows the distant lymph nodes listed, and so I just plugged them in here. Don't try to remember these. We've got good lists in the regional section for regional nodes, and now we've got a good list for what distant nodes are for breast. And so use your lists and try not to remember what those are. Okay, so code 70 includes METS in other areas with or without distant lymph nodes. Code 99 is no longer used for abstractors, and the sum stage then would be distant. Okay, the Some Stage Manual, there is a standalone manual. It is a PDF. This is really not changed. If you wanted to download it, you certainly could. It's also found in the SEER RSA under each schema. College programs are directly coding Some Stage 18. If you are in a non-COC program, it is derived. It is very easy to look up your Some Stage. So again, don't guess, don't try to figure it out from your TNM and your EOD. Quickly pull up the manual and just look and see what your Some Stage is. Okay, just a few more slides to clarify some areas. So the tumor size clinical was another area we found below the desired 85% goal, and it was at 69%. The reference for the tumor size fields are found in the SEER manual, page 114. So tumor size clinical is the size before any treatment. So that means before surgical resection, before any neoadjuvant therapy. It is the clinical classification. You could use the diagnostic workup, the physical exam, imaging, path findings, surgical exploration without a resection. So this is a clinical window. The clinical tumor size or the pre-treatment size is essential for treatment decisions and prognosis determination for many types of cancer. The tumor size clinical is taken from any of that clinical information prior to neoadjuvant treatment. In the SEER program manual for tumor size clinical, bullet number 7 says you can take this information from imaging would be your priority. You can take it from a surgical op report, anything that's explored that would visually be measured. This would be taken as a lower priority over a physical exam. So you want to, you can use the biopsy procedure or the op report, not using a path report, especially for a core biopsy. So there are several notes about rounding this size, less than or greater than, the priority order for where to take this information from. Most often you'll get a size from a core needle biopsy. However, do not code it in this field. You want like the imaging size, physical exam size. That's the best size. Under note number 9 in the SEER manual for tumor size clinical, there is a example of an incisional biopsy that happened to remove the whole tumor, and it actually becomes an excisional biopsy. So you would record the tumor size in tumor size path. It was never the intention to completely remove this tumor, but it happened. So the example they give is the mammogram did not give us a size, it just showed microcalcifications. The path of the left breast upper outer quadrant showed a size of 5 millimeter. And then when they did a resection of the left breast, there was no residual carcinoma identified. So the clinical tumor size then becomes 999 because that stereotactic biopsy, needle core biopsy size goes in path if there's no residual. So you really didn't have a clinical size on imaging. And then your path tumor size code becomes 005. So this is confusing. It's not going to happen that often, but it does happen. And so you need to know how to implement those tumor size fields. Both of these examples have core needle biopsy sizes. Both have imaging sizes. So the priority would be to use the imaging as the priority. So for example, 1, this would be coded a clinical tumor size of 0.25. Example 2 is similar, and we also have a TNM stage by the oncologist that confirms basically that range between 2 to 5 centimeters. So the clinical T confirms the imaging size, and we can use the 0.34 from imaging and not the needle biopsy or the core. There are site-specific notes for tumor size breast in this SEER RSA, and these are pretty much carried through whether you're looking at tumor size clinical, tumor size path, or tumor size summary. So we have our general rules for rounding, but site-specific rules override the general rules. So for breast, there is an exception to rounding rules that you are going to round the tumor sizes that are greater than 1.0 millimeter up to 2.4 millimeter. You're going to round that to 2 millimeters or code 002 for your tumor size. The purpose of this exception is so that the size recorded in the tumor size field will derive the correct T category. So do not apply this to any other site. Record the solid primary tumor that has been resected for tumor size path. So this path classification does include op report, path report from the resected specimen, but this tumor size path still needs to be before any adjuvant treatment. That path size is important prognostic information. It's valuable clinically and for research on surgically treated patients for most cancer that has not been treated. There's several rules starting on page 110. This neoadjuvant rule has been updated in the 2021 SEER manual, but there is an error in that 2018 to 2020 SEER manual. The STOR manual does have it stated correctly. So for tumor size path, we will code 999 for unknown when there's no excisional biopsy or tumor resection. Always code the largest dimension of tumor, whether it's from the excisional biopsy or a complete resection. So if there's neoadjuvant treatment given, tumor size path will be 999. And like I said, this is a change to what is in the SEER manual right now. The STOR manual is correct. So make a note of this, tumor size path 999 if there's neoadjuvant therapy given. So the same note that we talked about for rounding, the exception for tumor size path. And then for tumor size summary, like I said, this is derived for non-COC programs, but for COC programs, you must code this manually. So record the most accurate measurement of a solid primary tumor. Usually this is the surgically resected specimen, and the reference is the store manual on page 207. If you are coding tumor size summary directly, please read through these examples and coding guidelines. If you have neoadjuvant therapy followed by surgery, do not record the size from the path specimen. Code the largest size of tumor prior to neoadjuvant treatment. And if it's unknown, you will code 999. If there's no surgical resection, then the largest measurement of the tumor from the physical exam, imaging, or diagnostic procedures prior to any form of treatment is the size that you will use. Again, the tumor size summary rounding rule, there is a specific exception. And so this is the same exception for all three of these fields. Okay, so the best way to practice EOD is to work on your own in SEER Educate. The rationale you get, whether you get correct or incorrect answers, the practical applications of these cases is helpful. So please take time to do the homework. The goal is to become 90% proficient. And if you have any questions, you can always reach me by email. Thanks for listening.